Hello, everybody. Welcome back to the podcast, where we have another great conversation for you. Today, I welcome back Dr. David Rosensweet for our third conversation. So, if you haven't checked out the other two, I highly recommend that you do it. So, if you don't know who Dr. David Rosensweet is, he graduated from the University of Michigan Medical School in 1968, and he's been in private practice ever since then, pretty much. He's had offices in New Mexico, California, Colorado, and is currently in practice in Southwest Florida. Dr. Rosensweet was the clinical physician involved in the very first nurse practitioner training program in the USA and in charge of health promotion for the state of New Mexico. Right now, Dr. Rosensweet spends most of his time helping women and men with their hormonal issues and transitioning through different stages of life, along with addressing some other topics like how stress influences not just our hormones, but how we function on a day-to-day basis. Am I correct, Dr. Rosensweet?
Yes.
How are you today? Thanks for coming back.
Yeah, my pleasure. I mean,
Good. So, Dr. Rosensweet, there's been a lot since we last spoke almost a year ago happening in the world of hormones. Lots happening in perimenopause and hormone therapy. What's your opinion on all these changes over the last few months?
I think it's excellent that the United States Health Department has voted to remove the black box warning about the dangers of estrogen. It never should have gone on there in the first place because there was no evidence for that. It warned women and healthcare providers not to use estrogen because of the false reporting of a very faulted study, the Women's Health Initiative. And that was horrendous. 18 million American women who are on hormones, most of them went off way down below 2 million. And there was very severe health consequences to those individual women. So think about if you knew any of those individual women,
Mhm.
because that's more what my experience is I'm meeting up with the individual human beings, and the numbers are different than the stories of women who lost their lives, lost their bones, lost their cognitive function, lost their libido, their vagina, because of that drastic decrease in treatment. Well, anyway, the best news is a fairly well publicized retraction of that warning has occurred in the United States, and that's sparked a new revived interest in more women getting treated. I think that's terrific. I think that's a great thing.
With the retraction, did you read anything specific yourself put out from the FDA and what they were saying?
Well, I watched the actual proceedings and I saw the speakers, and I just know that the result is the removal of the warning.
You've always been a fan of estrogen. You're involved in the creation of Bi-Est. And if I'm correct, you've always, and we spoke about this on our last podcast, your preferred form was always estriol. And that's why you like helped with the creation of Bi-Est. So it was estradiol and estriol. And
Well, I want to maybe correct you there. Um, Actually, the divine designer of women was the designer of estriol. We did a study on, we interviewed 600 young women between the ages of 18 and 29, and we were able to actually test 100 of those women because uh, they fell within our criteria of being healthy, being normal BMI, being regularly menstruating, never been pregnant, and never on hormonal birth control. So 100 out of 600 qualified. And out of that, 24 women actually, we have evidence of them ovulating. That means there's a normal cycle going on. 24 out of 600. That's really remarkable.
Yeah,
We
well,
did get that. We did get the results. And just like it was proven in the 1960s by a medical doctor at the University of Nebraska, there was more estriol in these young women than there was the sum of the two most potent estrogens,
mhm.
estrone and estradiol. Now, I definitely was not the originator of Bi-Est. That was Dr. Jonathan Wright, beloved pioneer, friend. He did that in 1980s. He said one of his patients challenged him, why do you want to give me horse urine, estrogen? Can't you find something molecularly identical? And he did. And he designed it so when he gave the woman the formulation, the estrogen formulation, it produced a urinary hormone profile that looked like the young, healthy women. And what that required to was in most women is to give them 80% of that formulation be estriol and 20% be estradiol. We do not leave out estradiol, no way. But if you give most women, not all, that particular formulation, 80% estriol, 20% estradiol, you'll produce a hormone profile in a 24 healthy women. So the original designer was actually,
God.
yes, and then Dr. Wright and Dr. Henry Lemon, who originally did the work, Dr. Lemon showed that young healthy women had 1.3 times as much estrol as they had the sum of estrone and estradiol.
Mhm.
That was young healthy women. His main interest was to examine the hormone profile of women who had breast cancer, and he found way less estriol.
That's what we spoke about in our last podcast because I had heard you on another conversation like a year or so ago mentioning part of the reason why younger women don't get breast cancer is because they have a lot more estriol than older women do, and that form of estrogen is more protective.
Well, it's a very challenging subject. How do human beings get ill? How do human beings get cancer? How do women get breast cancer? I like to look at it basically in a different way.
Mhm.
And if you imagine that we had a video of any given woman from the time she was in the womb, 24/7 until she's the age that she is, and we had an editing device to edit out all the good stuff, all the good nutrition, all the good exercising she did, all the fun, all the love, all the good living she did. And we pressed an editing button and all that footage disappeared. What would be left behind would be everything that was challenging to her health,
Mhm.
all the dietary indiscretions, all the too little or too much exercise, all the toxic exposure, and all the dysfunctional response to stress. I'm not saying stress, I'm saying response to stress.
Mhm.
There we would see the causes of illness and ultimately cancer, a very severe illness. So to single in on estrogens and a metabolite, I think it's misplaced. I think it really you lose the big picture of how people get ill.
Well, yeah, there's a lot to be considered when someone gets ill or develops cancer. Estrogen is only one part of the conversation. But what I'm trying to get to the bottom of is when we're only looking at estrogens, estriol seems to be the more protective form and would be a factor amongst other things in why certain women don't, especially younger women, don't get these more estrogen dominant, shall we say, cancers compared to others. And that's where trying to break up the confusion, because this estrogen black label warning, it just was broad spectrum. It just said estrogen. It didn't break it down into all the different metabolites. So I think that is a little bit misleading to women because there are practitioners out there who are only prescribing estradiol, so not the estradiol blend. And I think that could be putting some women at risk.
Well, to dive into the weeds even further, and this is what Dr. Wright began the discovering. Um, he worked with Dr. Lemon's information that the conclusion was estriol could be cancer protective.
Hmm.
And then over a decade later in the United States, a researcher at Tulane discovered the second estrogen receptor site beta.
Yeah.
And what we see in a young menstruating woman's cycle is the whole first part of it is in preparation for pregnancy. It's called the proliferative phase.
Mhm.
A new lining is formed in the womb, the endometrium, and this really astounded me when I first heard it. The breasts are being prepared for breastfeeding every single menstrual cycle. And new cells are formed, new breast glandular cells are formed in a woman's breast during the first half of her cycle. Many women feel this. They
Mhm.
feel their breasts get fuller as they approach mid-cycle and later. There's new cells there. And then if they don't get pregnant, everything reverses. All these cells disappear. The new breast cells disappear. The uterine lining cells are shed in menstruation. And what we learned is that the proliferation phase, the buildup, the
Mhm.
new cells, was the interaction between estrogens and estrogen receptor site alpha. That was its name.
Yeah.
And the deproliferation, if there's no pregnancy, the disappearance by a wonderful process called apoptosis. I think that's wonderfully named. Those cells disappear, and that's under the influence of estrogen interacting with estrogen receptor site beta.
Hmm. How does that
And
work? How does I mean, I was going to say how does the body know to do this, but we already know the body is a miraculous place that we'll never understand.
it really is, you want to believe in the divine, just study the
Hmm.
human body.
Yeah.
It's staggering. So many times in medical school, I was so moved to tears when I saw what was going on in there, on every level. Oh my God. Well, the principal inspiration to estrogen receptor site alpha,
Yeah.
the proliferative phase in
That's
preparation with
estradiol.
new breast glandular cells, that's estradiol.
Hmm.
The principal inspiration of estrogen receptor site beta, which is behind the deproliferation,
Hmm.
is estriol. So there's some deep physiology there. Why in the world wouldn't you want to do both?
Hmm.
And
Well, there's balance. It's like homeostasis. One side,
yeah,
the scale balances out the other.
so a lot of women who have been on estradiol and even estradiol alone, the evidence is it's cancer protective. Women who are on estradiol, as opposed to not being on anything, they have less incidence of cancer.
Do
Even
they
women on Premarin, horse urine derived estrogen,
do they also have elevated
they have less incidence of cancer.
But do they also have elevated levels of estriol as well, or it's just
Not
the
in not
estradiol?
in oh, the women on Premarin?
And who are just on estradiol, do they have high natural
No,
levels
they
of
don't. They
estriol?
don't. And we've shown that because we've done a lot of studies. I've had 33 years specializing in this, and I love doing medical studies, and we do them. And in the early 2000s, a friend of mine said, "You don't have to give a woman Bi-Est. Just give her estradiol. Her body will convert it to estrol." So I changed every one of my women patients who were on Bi-Est to estradiol. And after a certain period of time, we tested them, and I was absolutely wrong. They did not come up with the youthful, healthy, normal distribution of estriol in the urine. They didn't do it. It wasn't true. The estradiol did not convert to estriol.
That's what
And
I
there's
was
people out
thinking.
there saying, just give them estradiol. The biochemical pathway says estradiol will convert to estriol. No, it doesn't do it. Good theory, folks. It doesn't do it. I saw it with my own eyeballs.
Yeah, I didn't
So,
think. Maybe estrone, but not estradiol.
well, they're all related. I
Hmm.
mean, estradiol converts to estrone. Estrone converts to 16 alpha. You know this, we're really down in there. And that converts to estriol. So theoretically, my friend and colleague was theoretically correct. All I had to do was give them estradiol, they would wind up with estriol. But it did not happen. And I've explained this to proponents of just give them estradiol,
Mhm.
and they don't let it in.
So I have two questions here then. So with your colleagues, is it that they saw some women maybe converting estradiol to estriol
They
or
weren't looking at it. You
oh, so
don't
they were
get
just
to
guessing.
see, you don't get to see it because you can't see it on blood. It is on 24-hour urine hormone testing.
The Dutch, yeah.
That's not the Dutch test. No, I'm not I'm not a fan of the Dutch test at all. It's got too many possible error places for errors in it.
Mm,
But on 24-hour urine collection, you see the estrogens and you see the metabolites. So they weren't doing that, so they didn't see it. They had no evidence. You can't see it in the blood. They're very fond of saying estriol isn't in the blood, but when it's produced, it disappears really quickly. So you can't really capture it in the blood unless you have a woman who's pregnant.
mm. So do you remember when we spoke and I had mentioned that I tried pregnenolone, and you said I probably didn't need it because I was so young. But I'd mentioned when I tried pregnenolone, I seemed to convert it really fast into estrogen because I got the swollen breasts, I got the heavy bleed, I put on the weight, and normally I don't have those symptoms at all, which makes me think. I think I had also told you that my sister has all the symptoms of excess estrogen or estrogen dominance, like all of the issues. And I didn't, so women present differently, even if they're sisters. But then when I used pregnenolone, I was like, well, maybe I'm still very sensitive to converting estrogen down certain pathways because I responded within like 24 hours. I put on like 8 pounds and it was all fluid. So that makes me wonder, are there certain women who would or wouldn't convert estradiol to estriol for whatever reason, whatever metabolic pathways or genetic predispositions they might have?
Well, I don't know how many women I wound up testing. This was the early 2000s, and they were my patients, all of them. And I didn't see one case of where the estradiol converted all the way to estriol. But you never say never in medicine. And here you are. I mean, pregnenolone is a different story.
Mhm.
And when anyone who's ever studied biochemical pathways, we produce these hormones in our own body. And we actually produce them out of cholesterol. And cholesterol gets converted and eventually to pregnenolone. It's like the great grandma of these steroid hormones. And pregnenolone gets converted to a lot of things: progesterone, estrogens, corticosteroids. It's way up there on the production. So you could theoretically get estrogens from pregnenolone. In fact, you are living proof of it.
Yeah, and I said it to Carol, our mutual friend, And she's like, yeah, it sounded like I had, as she terms it, estrogen kickback. I also, do you know Dr. Brownstein talks
Oh
about
yeah,
thyroid? And I
yes
had
I do.
mentioned it to him, and he just thought that because I was so young and I sleep well, that I already make enough pregnenolone, and by adding in more, it just gave me too much pregnenolone. So, but I because of the symptoms, I feel like it was more the estrogen issues.
Yeah, that's the place it went.
Mhm.
It favored that, and I agree with Dr. Brownstein. Uh, and because of, of what happened to you, I've never wanted to give women the basic thing and let their bodies convert it, however they do it.
Yeah.
Like I've made the joke, why don't we just eat butter and a lot of it and let our bodies convert the butter to cholesterol and the cholesterol to the various hormones. And I think we just don't have control about where they're going to go.
Yeah.
And so my favorite thing to do is to treat with the actual parent hormones.
With the end
Treat
product.
with estrogen, treat with estriol and estradiol and progesterone, and treat with DHEA and testosterone.
Well, it's the same with probiotics. People take probiotics like there's no tomorrow, but there's no guarantee where those bacteria are going to go, especially if you eat Wendy's all day long and take a probiotic thinking you're protecting your gut. Like it doesn't work like that. So back to the estrogen then, the estradiol specifically. So you were seeing that no, it wasn't converting to estriol. It is the estradiol that is protective.
No, I didn't conclude that. Um, but worst case scenario, back to 18 million women being treated, which is 40% of American women who are in menopause, were being treated with Premarin. What they did is they collect the urine of pregnant mares. That's where the name came from. Because the urine of mares or humans or any animal has hormones in it.
Mhm.
In fact, the first bioidenticals that we know about, the Chinese, 1,000 years ago, the aristocracy would set up these outhouses for young women and young men, and the young women would pee in one outhouse and the young men would pee in another one, and they'd collect all that urine and they'd dry that urine out, and there'd be this powder left behind,
Mhm.
and the aristocrats would eat the powder
Mm. Yum.
and get the hormone and get the hormones. So the Premarin idea was really invented by the Chinese 1,000 years ago. Collect the urine of horses. The difference is that the urine of horses doesn't have the 50% of the hormones in the urine of horses have never been seen by the human female. So I was never a fan of it.
Mhm.
Plus, the horses are kept in stalls and catheterized and the whole story. But, many, many women were served greatly by Premarin. And that study that everyone freaked out about falsely, that study was done with horse urine derived estrogens. And we learned that the women who were on pure Premarin had less incidence of breast cancer. So even horse urine derived estrogens, I didn't say estradiol. I suspect that pure estradiol leads to more health of women in menopause, and my guess is pure estradiol also would be protective.
Is that in
So the whole
context?
myth that these hormones are causing cancer, they're not causing cancer.
Where do you
That's
think that myth, regardless of the Women's Health Initiative, there's a lot more people speaking of it nowadays. Where do you think that's coming from?
well, speaking about risk from hormones, show me the money. Show me the studies. I don't see studies that suggest that hormones cause cancer. I don't see them. There's been false interpretation because of the Women's Health Initiative. That was the worst culprit. There was the Premarin arm, and even in that original study, the women on Premarin alone,
Mhm.
they had a less in incidence. But part of that study was Premarin combined with a very funky molecule called a progestin. It was called Prem-Pro.
Mhm.
They originally reported in the original article a 1.26 relative risk, which they named in the article was not statistically significant. Every scientist, every doctor knows that when they say statistically insignificant, what they mean is don't draw any conclusions about that. But they did. They drew, that's where that false rumor got started. They continued to follow those women, by the way, and by 2006, 4 years later, that risk had reduced to one, which means there was no risk at all, even with Prempro. So what I'm saying is we got to erase this idea that hormones cause cancer. They don't cause cancer. Lack of hormones, boy, that is really not just a risk, it's almost a certainty that there's going to be big trouble sooner or later. And who gets to see this? Doctors and nurse practitioners and people on the front at 60-year-old women, and then you look at 90-year-old women. And what's happened to the 90-year-old women? They lose their muscles. They have to go from cane, walker, wheelchair, and adult diapers. They lose their vaginas and they get bladder infections and they wind up with adult diapers. Many of them lose their ability to think. The consequence of these hormone losses for most women and most men, because men have a very similar thing happen, that's almost a near certainty. That's not a risk. Osteoporosis, where they fracture a hip in older people, that's the last year of their life. Even if they get fantastic surgery, and surgery can be fantastic, they still die within a year, a lot of them.
When you're using estrogen, you mentioned before, and I don't know if it's changed because it's been a year since we spoke, that you always pair estrogen with progesterone. Is that still the case?
100%,
So you're never giving estrogen alone.
as in never. Well, a woman's body produces up to 100 times more progesterone than it does estrogens.
Mhm.
Progesterone is a profound, amazing hormone. So 100% of the women that we start on hormones, they start out with Bi-Est and progesterone. And about 90% of the women that we start off with hormones, we add in testosterone and DHEA because by midlife, most women have also got major declines in testosterone. And in a young woman, there's more testosterone than there is her most potent estrogen, estradiol.
Mhm.
Testosterone is not a male hormone, it's a human hormone. And testosterone is one of the main things that preserves natural drive and muscles. I remember sitting in a lecture when I was a senior medical student. Tell me if I'm diving too deep in the
No,
weeds here.
go, go, go.
I'm sitting for a noon lecture in the University of Michigan Hospital in 1968. And we're getting a lecture from a gerontologist. That's a specialist in treating older people. And I didn't want to go to the lecture. I was a young guy. I don't want old people were not in my mind because I was in my late 20s.
Yeah.
But I went and this is probably the only noon lecture that I can actually picture myself sitting there and listening to this gerontologist. And what he said is, You're senior medical students. You know thousands of diagnoses. Let me tell you what's happening to older people.
Mm.
They're losing their muscles. They fall on osteoporotic hips and they die, or they're losing their mind. You want to do something for older people? Protect their muscles and their bones and their mind.
Hmm.
They didn't know at that time how related those were to hormones,
Hmm. I
because that's
remember
what's happening to older people.
when I was doing my personal training a long time ago, like 18 years ago, I remember clearly because at the stage I had my two grannies were still alive and they had both fallen and broken their hips. And I remember the lecturer telling us then that if a woman falls and breaks her hip in old age, the chances of her dying within 4 years are astronomically high, and that stuck with me forever.
Yeah. So why I'm saying this is, for one thing, it's not hard to replenish these hormones, and it's never too late. It's ideal when a woman is starting to get declines called the perimenopause, but I say it's never too late. I started treating my mother when she finally would let me, when she was 86. We have a video of her no longer needing her cane.
What were you treating her with? Just everything?
Yes, all the hormones. And I was treating my mother-in-law, and she happened to have had three preceding heart attacks, but she had fallen and broken her femur, her clavicle, her humerus, her upper arm bone there, because she got weak. And we have a video of her at the age of 85 standing up after recovery with her arms up in the air after I treated her for a while, not needing her arms to get out of a low, soft couch. Very impressive.
So were you cycling the hormones like we would with
No,
younger, or you're just every
no,
day?
every day.
Because I remember Carol telling a story of a doctor she was speaking to at A4M who was still, shall we say, treating his wife with hormones, and she was in her late 60s. And whatever way he was cycling the hormones, she was still ovulating and having regular bleeds each month, which is quite impressive and shows you what, again, what you're alluding to of what is possible when we use hormones correctly.
Well, 99.9% of the women that we treat with hormones, we don't use estrogen doses that high.
Mm.
In order to get that bleed, you have to give dosages so high that you wind up doing tests. When you test these women, they have between 3 and 8 times the upper limit of normal on their 24-hour urine hormone tests. You need supercharged hormones. And that has a risk associated with it, so we don't take that risk except with rare exceptions. So we never treat women that high.
If I'm recalling correct from the story Carol said, was that this doctor wanted to keep his wife in like a replication of her youthful self, and that's why they were maintaining a cycle
I,
as if
I,
she
I know
was
these
younger.
people. A good friend of mine who's a doctor and I, because we started talking against keeping the bleeding going,
Mhm.
they served us with their attorneys to cease and desist talking about them at lecture when we lectured. I know them
Oh,
very well.
had I known this, I wouldn't have brought up the story.
It's okay. It's an important story because what they didn't know was they were using dosages so high, much, much higher than a young woman. For example, they use 16 milligrams of estradiol in the third week. And that's 4 times the amount that our highest treatment levels are. And they produce 24-hour urines that have between 3 and 8 times the upper limit of normal of
Mm,
estrogens that a young, healthy woman does. So we don't believe in this. And here's the bottom line, and this may be the most important thing that I say today. I do believe that a rich amount of estrogen and a rich amount of progesterone and a rich amount of testosterone is the best treatment,
mhm,
but not so rich as you put a woman at risk. And the risk you can put a woman in if the estrogen dose is too high is that you get stimulation of breast glandular tissue. You get new cells. That's what happens to a young woman every single month. Her estrogens get so rich that she gets proliferation of breast glandular cells. But in a menopausal woman, that can lead to increased breast density,
mhm.
which is one of the few known risk factors for breast cancer. That's it.
That's that
Increased breast density.
proliferation.
That's proliferation. So we don't want to give a woman so much estrogen that she gets any extra breast cells. How did she get those cells? Cell division. Well, that's a very vulnerable place. Cellular mitosis, exposure of DNA, the genes and stuff. You don't want to see a lot of proliferation in a menopausal woman who's older and doesn't have necessarily the most powerful immune system to get rid of mitotic cells that don't belong there.
So
So we don't want to
basically,
increase
I was just going to say, so basically, too much estrogen in this woman is putting, and
putting
I
her
am
at
going to
risk.
be bold, yeah, it's increasing her risk.
And it's not saying she's going to get breast cancer.
Well, it's not
Cancer is very
guaranteeing, but it's
complex.
just, yeah.
And then I want to give you this occurred. I was invited to speak in front of the National Academy of Science, Engineering, and Medicine when they were looking at the safety and efficacy of compounded bioidentical hormones. I testified in front of them. I wound up testifying 3 times. And the first testimonial day, I was on a panel. I was allowed to speak myself, but I looked at who else was on my panel. And there was a woman doctor, and what I knew about her is that she was on that estrogen dosage that brought the bleeding back. And I knew because I had done the studies myself of how much estrogen that took to do that, and that that was not safe to me. And I also knew it was a bugaboo of the committee members. They had revealed that to me in my pre-speaking interview. They told me what they were bugged about, and that was one of the things they were bugged about. The women were getting these super high estrogen doses. And so as she's sitting down during the coffee break, I'm already seated. She introduces herself to me. She's sitting right next to me, and I say to her, "Are you going to tell them that you're on that hormone dosage that brings your period back?" And she winked at me and said no, because she knew it was a grievance herself. And I went out to lunch with her and her son, and she was 65. And I promise there's a moral to this story. If you can hang in there with me.
Go
Is it,
on, yeah.
is it too many words? Too much
No,
information?
go ahead.
And so she told me that at the age 55, she's a practicing medical doctor. She's starting to not remember things about patients,
Oh,
and she's starting not to remember their names or anything about them. And she got so scared that she was going to have to go out of practice at the age of 55. And her mom had dementia, and her mom's sister, her aunt, had dementia,
mhm.
and she was scared. But she knew about that estrogen could help restore cognitive function in some women. And indeed it can. And in women, if you're having brain fog and you're not thinking clearly, get thee to a hormone provider. Because so much of it, not all of it, but so much of it can be reversed simply by getting the estrogen back. I promise you that. So she's telling me this story that she started taking estrogen, she started clearing up. She kept taking more and more and more until she cleared up entirely. And I was sitting having lunch to her at the age of 65. She was still in practice and she was as clear as I was.
Hmm.
And was taking so much estrogen to clear herself up that she started bleeding again. So
Was
you
she
never
also,
say that, pardon?
I was going to say, was she also taking progesterone too, or just
Oh,
a,
yes, absolutely.
was she taking a
Absolutely.
really high dose of progesterone as well?
I don't know the exact dose, but probably she was savvy. She was smart about it. But the moral of the story is you never say never in medicine.
Hmm.
Yeah, there might be increased risk for breast glandular cell proliferation, but for a woman who's losing her mind, is moving towards dementia, it's one of the scariest things that happens to women, young women.
Hmm.
And I can tell you because I've had a family member develop dementia. It's not good.
My granny had it.
And yeah, and here I am sitting to her, and she's clear as a bell. So you never say never in medicine. There's always exceptions.
I have a couple of questions. First, what is the average age of the women that you're treating or starting on estrogen?
It varies a lot. It used to be pretty most common to meet up with these women who are starting to have symptoms in perimenopause in their mid 40s to mid 50s. But it's getting younger. Now there's more women in their 40s and early 40s that I've ever seen in the course of my career.
Mhm.
But women come to us at all ages. Once they lifted that black box warning, there's women who've 20 years with no hormones. They're coming to see us now too. So I wouldn't say there's an average. I'd say, and I say to any woman at any time, hey, see if you can find someone to prescribe these for you because they can help you almost at any age. We'd rather get the women younger. That's the best time, the perimenopause.
I
But
think
we'll
so. Prevention is
and
always
for the
better.
older women, sometimes we got to do a few heart screening procedures to make sure that the hormones are going to be okay for them. But
S-
at any age.
So the next question is, why do you always prescribe progesterone with estrogen? Why not just prescribe estrogen by itself?
Well, I am not messing with the original design. I'm staggeringly bewildered and fascinated by what a woman's healthy hormonal internal stuff is.
Mhm.
And I'm not going to try and invent a new biochemical woman. I think it's a big mistake to
We're
not,
perfect the way we are.
yeah. And the more you get into the design, the more astounding and amazing it is. You can't even get your mind around it. Like I say, you want to believe in the divine, study the woman's menstrual cycle. That'll convince you if you haven't believed in God yet. And I don't want to mess with why in the world would someone want to do different than what is in the natural woman's body? And progesterone balances estrogen, and that's very important. And testosterone is critical for many functions. Why would you want to leave something out?
But
If
there's a
someone
lot of
got,
there's a lot of practitioners that do though, a lot more, especially now that the black label warning's been removed, that are only
well,
using estrogen.
they're wrong. That's the simple answer. They're incorrect, and it's not safe.
Mhm.
I don't like to malign anybody, but I don't like bad medicine.
Can you
And
help
that's
the
bad medicine. Just treatment of estrogen alone without treating with progesterone or testosterone, that's bad medicine.
can you
There's no
help
place for that.
can you help the audience understand, because I'm really trying to get your point of view across on why you think it's unsafe for these doctors to only prescribe estrogen?
Well, estrogen stimulates, estrogen proliferates, progesterone balances the stimulatory effects of estrogen. But I want to go back to my basic premise. Why in the world was the human female designed to have 100 times more progesterone than she has estrogen in her normal cycle while she's cycling. I'm not talking about pregnancy. I'm talking about normal cycling.
Mhm.
Oh, do you want to invent a new woman? You think you're going to do a better job? Well, we'll just give her estrogen, as if there wasn't a purpose for progesterone. And the same goes for testosterone. You leave a testosterone out of a woman's treatment plan, it's almost a guarantee that she's going to lose muscle to the point where she goes from cane to walker to wheelchair. That's a big move.
To a bed, yeah.
That's what the gerontologist told us.
Mhm.
Sarcopenia, loss of muscle. Why do you see elderly women and men with canes and walkers? And then you don't see too many of them when they move to a wheelchair because they're in nursing homes and assisted living facilities.
Mhm.
You don't want to leave out testosterone. You don't want to leave out anything. If someone was low on insulin, there isn't a medical doctor on the planet that wouldn't want to replenish insulin.
Mhm.
Or if someone was low on thyroid, there's not a doctor on the planet who wouldn't want to give back thyroid.
Well, we could argue about that one.
I know some people are missing it. Yeah, they're not totally hip to what it really takes, thyroid.
What about treating? Because, again, to refer to Carol, she loves progesterone. What about treating only with progesterone?
Well, there is a time in the perimenopause where I hold that to be totally appropriate. Because when you look at the science, what we've learned about younger women is sometimes their progesterone is declining earlier and deeper than the estrogen declines. In fact, in our teaching program, we have a slide showing that earlier and deeper decline. And they're getting symptoms, young women in the perimenopause, or even young women in their 30s, or even in their 20s.
Hmm.
They're getting symptoms of no balance of progesterone. They're getting pain, irritability, and they're not sleeping well. They're getting symptoms of that early decline. So a lot of good was done in the 1980s, 1990s by a medical doctor who suggested that women be treated early on with progesterone alone.
Was that John Lee?
It was John Lee. And Carol Peterson is who you're talking about.
Hmm.
And she has been treating, but part of the treatment of women with, I don't know, probably on 40 years now. And she's a big advocate of progesterone. Yeah, you want to balance that estrogen with progesterone.
The last question I have now, I was hoping we could speak about grief, but maybe another conversation. But this one I think is important because you mentioned you don't like the Dutch, and a lot of practitioners and even women do like the Dutch. And one of the things that women tend to focus on and practitioners a lot on the Dutch is the metabolites of estrogen and oh, if you have higher 4OH or 16OH, that increases your risk of cancer. What do you have to say to that?
Well, as early as the 1960s, 24-hour urines were reporting the estrogen metabolites. Dutch didn't invent that. They learned that from the 24-hour urines. And at one point, their owner even suggested that the 24-hour urine was the gold standard.
Mhm.
But there's issues. And one thing we did is we've done a study in which we took a woman and a man, and we had them collect 24 hours of urine and simultaneously on the same day do the Dutch test and do it from another lab as well and compare the results.
They're different.
There were big differences, which would have resulted in different recommendations.
Hmm.
Like you would see someone with a low testosterone from one of the labs and a high testosterone from another lab. And what's the provider supposed to conclude? Better reduce the testosterone dose from the second lab but or increase the testosterone, same specimens. There's pharmacokinetic issues with the Dutch test in that you don't take your hormones until 9 o'clock in the morning when you collect the 9 o'clock specimen. Then you take your hormones and you don't collect your urine until 5 o'clock. That's 8 hours. Those hormones could have come and gone by then.
Hmm.
You're not getting a true peak there. So you're getting missed. So there's reasons. And then you're urinating onto filter paper. And as one living expert on GCMS technology, which is the best lab testing stuff, said, why would anyone want to pee on a filter paper? Why don't they just use pure urine? Because steroids are sticky. And everyone knows in laboratory medicine that the extraction process, trying to extract steroids so you can measure them from filter paper, is fraught with possible error. So I'm not scientifically, I've never been behind the Dutch. People will argue with me all the time. Everyone is entitled to their opinion.
Hmm.
But I'm going to give you my best shot, and I care about this to the extent that I want best medicine. And I cannot get behind the Dutch because I don't think it's best medicine.
So if women are getting a Dutch and then they're seeing very high metabolites of 4-OH or 16-OH, would you say, look, don't over obsess about that. It's not going to be 100% accurate, or what would your advice be to those women?
Big topic. For one thing, I've heard experts in the field say that the whole issue around the metabolites, increased 4-OH,
Hmm.
increased 16 alpha OH, that was a scientific declaration in order to sell a supplement. That
Oh.
was the motivation behind it. There's controversy about whether those metabolites are actually as risky as they are said to be. And we do weekly grand rounds for medical providers, physicians and nurse practitioners, and compounding pharmacists and PhD scientists. And we've been doing it for years and years. And twice we've had major presentations, including yesterday. One of our beloved medical doctors did a full report on the metabolites. And what I think, in more general terms, when a woman's body, I've seen the controversy, and one of our doctors who reported on this a year ago said, you can't really draw a conclusion. Some say yes risk, some say no risk.
Mm.
And we got to use our common sense here. Cancer has causes, a lot of them.
Yeah.
And that's why I take you back to the video. And you see the video of the toxic exposures. You see the video of this dysfunctional response to stress. These are the profound causes of cancer. Are metabolites the profound causes of cancer? Are they that strong? Well, there's evidence on both sides. But the bottom line is when we see those distortions, we don't immediately try and freak the woman out and scare her, which is rampant in medicine. Go and scare the patient.
Mhm.
Plant that seed in their mind. You better think twice before you go and frighten somebody because people are very easy to frighten. So you want to be very cautious about that. So you want to be sure that you know what you're talking about. Well, here I'm telling you, you don't know what you're talking about because there's controversy here. So you
There's
don't want to
argument
scare
over.
someone.
Mhm.
But when we see these abnormal process, we see these abnormal test results because we see them on 24-hour urine, not too common. We know something's going on. And what we think of first is the liver is not processing these like it usually does.
Mhm.
Why is that happening?
Yeah.
Because livers are challenged these days as almost never before.
Mm. And even the guts.
And there you go. One of the big challenges to the liver is the gut and dysbiosis in the gut. So we don't totally disregard it. When I see those abnormal metabolic pathways, I number one, do not frighten the woman. You better have something to stand by.
I'm just curious, the supplement you referred to with the metabolic pathways, it wouldn't happen to have been dim, would it?
It's precisely what
Uh,
it is. Early on, when I first learned about this, I was really excited. Here I could take a test result and give someone to correct it.
mhm,
Give someone DIM or indole 3 carbonyl, which are really derived from broccoli for the most part. Eat a lot of broccoli. It's good for you, period. But I never got the success. And I raised that at Grand Rounds yesterday, and I was asking our whole group, there was 45 people, something like that, on the Grand Rounds. These are medical doctors, nurse practitioners who are specializing, most of them, in hormones. I said, "You've given DIM. Anyone have great results?" No. And I think the reason is it isn't so simple that if you're not seeing normal metabolic pathways, you either got some genetic issue going on there, or you've got some subtle injury to the liver. And this day and age, with all the toxic exposures,
yeah.
these livers are overworked.
Mhm.
How do
Yeah.
I know?
People take DIM thinking it's going to be a panacea, but overlooking that they do have detoxification issues that they're not addressing. So the DIM doesn't do anything, or in some
So
cases,
this,
it makes
yeah,
them worse.
it's a distraction. You think you're doing the right thing, but maybe you need to really go after liver health, or like you said, the gut health, which is can be a problem for the liver, or you need to detoxify. You need to get rid of all the toxic substances in your house, which is makes life cheaper, by the way.
So I think if we were to summarize this conversation, Dr. Rosensweet, what we're getting at is we're looking for balance, but also there's arguments on both sides of the fence. Nothing has been solidified in a sense that even back to what you're saying about the Dutch, some people like it, some don't, some people like them, some don't, that there's constant arguments on both sides.
Well, yeah, there's controversies. There's a solid, great body of knowledge about hormones that anyone, any professional, medical doctor, nurse who's devoted their career to focusing in on helping women and helping men, there's a solid, wonderful body of knowledge. Then you can do a tremendous amount of good. Even the women who just got Premarin, they did so much better than the women who didn't get it. So there's the solid body of knowledge that almost everyone would agree on. I could tell you what those things are. And then there's the questions at the periphery, at the edges. And because the field of hormones is so stunted because of that Women's Health Initiative, there's not a lot of specialists in it. So there's even more controversy. You don't see this kind of controversy in ophthalmology or in diabetology or orthopedic surgery. You see a little discussion at the edges, but they got a solid, gorgeous core of knowledge and experience, and they know what they're doing. This field is rampant with people who haven't specialized in it, got all kinds of opinions, are all over the internet because the whole field was stunted, but was set back by people losing interest in it because they were afraid to treat women in 2002. So I'm just going to give you my best shot. What I want to say is there's a great body of knowledge around getting good hormonal treatment. And there's some discussions around the edges. Bottom line, go get that hormonal treatment, male or female. It's so important. This is so important.
Well, Dr. Rosensweet, thank you for this honest conversation because it certainly was that, and not everyone is honest, unfortunately. And even though I'm sure you picked up, we don't agree on everything. Of course, you're the expert. I do appreciate having these open conversations so we can shed light on both sides, just like what you said, because the research has been stunted. You have a lot more experience than many of the influencers out there that we see.
I've
So,
been deeply blessed.
you have. And even like the knowledge base that you provide on Instagram and your website is just astounding. And I recommend everybody goes to check it out. And of course, I'll share it in the details. Is there
And
any?
you can give folks a link for a free copy of my book for women, Happy Healthy Hormones. Olga has it, and they can just download a free PDF copy of it.
I still have that link and I actually have it posted in my health and hormones group so
Beautiful.
everyone can get it. But is there, based on what we spoke about today, like the discussion around hormones, everything that's evolving around hormones, what would you leave women with now? Like there is hope on the horizon or what?
There's a lot of great work being done right now, this very day and age. It's only going to get better with the lifting of the curse. And here's your job, women. You do not have to go to medical school, but you do have to find a provider that you trust. That's your job.
Hmm.
And so you got to go shopping. That's what I did when I needed an ophthalmologist. I went through 5 different eye doctors until I felt right in my guts. I went, this is my doctor.
Hmm.
And that's what you need to do. And there's a lot of ways to do it. You can ask your women friends, especially the older women. Some of them are going to be on hormones, and a lot of those women are going to have some provider, a nurse practitioner, a doctor, a physician's assistant, a pharmacist that they really like and trust. And you can see it in there. You can see it in them
Hmm.
and ask them. Here's another thing to do. Go to your local compounding pharmacist and ask, look, I need hormones. You're seeing all the prescriptions. Which doctor would you recommend?
Who's
Because
prescribing?
they know who's doing the good work and they
Yeah,
know who's doing the fringe work. And then,
that's a good idea.
oh yeah, and then connect with us in the United States. We're working on Canada big time, but we're not there yet.
Keep doing it. We
We
need
finally have
help.
a pharmacy providing our organic oil base for topical hormones. That's a big subject, organic oil base. But in the United States, we're almost in all 50 states. So if you just contact us, we can set you up with a provider that's been trained by our method and we love and we have partnerships with.
Hmm.
So just email Olga at iobim.org and she can set up a referral for you to someone that we really stand behind because we train them and we're in partnership with them.
Well, thank you for that. I'll put Olga's email address in the description as
Yeah.
well for anyone who wants to reach out to her. I was speaking to her. She's very nice. So thank you for your time again, Dr.
And one
Rosensweet.
other thing, Shemaine, for women in Canada, we need providers there. So if you know a friendly nurse practitioner or medical doctor, that's where we're stumbling right there that wants to get trained by us. God, I have a lot of my family lives in Canada, in Vancouver and Toronto, and so we really want to get some providers interested in treating with the best because we have organic oil delivery system. So they can contact Olga too and
I,
inspire their provider. Say, we want the organic oil. Well, you'll see it in the book. Anyway, Shemaine, I don't want to take any more of your time. Thank you very
well, it
much.
just so happens I have a medical doctor that I collaborate with here, and maybe I'll bring it up with him because I know he's always eager to learn.
Great. And give them my personal email address
I
or
will.
connect me with Olga and we'll have a Zoom meeting.
You would like him a lot. He's
That's great.
ex-military and he's very open to everything.
Fantastic. Please connect us up.
I will. Well, thank you for your time, Dr. Rosensweet.
You're
Third time's
welcome.
a
Good to see you
charm.
again.
Yeah. Okay. We'll chat soon.
All righty.